I was first introduced to my colleague on the left, Tim Underwood, a few months ago when he did a presentation, a public presentation in Winchester on his particular subject. His enthusiasm for that subject and the straightforward way he explained what he was doing to his audience really quite wowed me and blew me away. And I hope that he will certainly do the same to you in a moment. Tim Underwood is a Medical Research Council clinician scientist, and he's also senior lecturer and honorary consultant surgeon here at Southampton University. He specialises in upper gastrointestinal surgery and a special interest in esophageal cancer.
Perfect.
Thank you very much for that. And he's currently working on a Cancer Research UK-funded project to sequence a cancer genome as part of the International Cancer Genome Consortium. Tim's going to talk to us about risk, something which we know quite a lot about. Tim.
Thanks. I also played rugby for Wootton Bassett when I was a kid.
Oh, you're one of the 10,000.
Yeah, and I'm going to give you an overview of what I do for a living, and hopefully you'll be able to see some avenues for innovation, some of the work we've done that innovates. Esophageal cancer is one of the fastest rising cancers in the United Kingdom. The incidence has doubled in men in the last 30 years. Death rate has gone up by 50% since I was born. 8,500 people have this disease every year in the United Kingdom. We're a specialist centre and we deal with it. At the time of diagnosis, 2/3 of people who present to a doctor are already doomed. They will die of their disease. We cannot cure them. The 5-year survival for this disease is about 13%. So if 100 people are diagnosed today, only 13 will be alive in 5 years' time. Terrible. We must do better. And that's why another reason that we're here. The pathway for treatment for esophageal cancer, if you are deemed to be potentially curative, is exceptionally demanding. It takes over a year out of your life of intensive treatment. It starts with the process of invasive investigations, CT scans, endoscopies, laparoscopies, a variety of things to see whether you can be cured or not. Then we say, off you go and have 3 cycles of chemotherapy, maybe with some radiotherapy, to see if we can make this a resectable tumour, to give your chance of being cured a slight increase by about 5 to 7%. Then we have a little holiday off here. We say it's okay, you've had enough for a while. We'll give you 6 to 8 weeks off, and then we'll bring you in for a massive operation that changes your life forever. And then your future is uncertain. I tell my patients it's like running a marathon without having done any training. That's what this is like. And the surgery is like having a major car accident. That's the sort of trauma that we put people through. And you could probably imagine that that pathway is fraught with risk and danger and worry and anxiety. And you know what? It is. And we're beginning to understand how we can modify and interact with that risk. We understand it profoundly and we can do things about it. I'm going to show you in a second something here. Okay? This is the important bit. This is the traumatic bit. That's the bit, if anything's going to save them, the surgery is going to save their life. Yes, please. And this is the operation that we do. It's a big, big operation. We operate in 2 body cavities. We put a big hole in the abdomen, and then we put a big hole in the chest, because the esophagus joins the back of your mouth to your stomach and runs through your chest cavity into your abdomen. This is the cancer at the bottom of the esophagus, where it tends to be. So we have to chop that out and all the blood vessels and lymph nodes around it. We then have to make this stomach into a tube and pull the tube up into the chest to rejoin onto the bit of esophagus we've left. It's quite a big deal, as you can probably imagine. I want you to remember this bit as being key to the operation. The join between the stomach we've pulled up into the chest, which is existing on 1 blood vessel, because we need it to be on 1 blood vessel to get the length, and the esophagus that comes down. The most feared complication for a surgeon, not necessarily for a patient actually, but for a surgeon after this type of surgery, is a disruption in that joint, an anastomotic leak. And I'll tell you about how we've been modifying risk around an anastomotic leak in a minute. Yeah, this is to remind me to tell you that you're going to have some lunch in a bit. So if you don't like surgical videos, either like the football scores, look away now, or leave, because I'm going to show you some surgery, okay? You've been warned, it's coming now. So this is, you'll see some technology and some innovation within this operation, hopefully, and you'll be able to recognise some of that. This is me here with some fancy laser headlights on, showing you how big an invasive procedure this is. We make a big hole in someone's belly. This is traditional way to do this operation. You can see there is trauma. We put an iron resident in and then we lift up someone's rib cage. You can imagine the insult that someone's being put through. And I'm showing you this not because it's anything other than the extent of what we have to do to people to treat this disease. And we use bits of technology. This is a harmonic scalpel that has made dissection of tissue planes far, far easier and quicker. And we use a variety of other kit at the right time during the operation, all of which has gone through process of innovation because surgeons have thought, could we do this better? Companies have thought we could do this better, and we've worked together to make it better. I'm going to skip ahead because operations are all the same and show you the second half, because at half time we do the abdomen, we close it, I go off for some lunch, genuinely go off for some lunch, recharge, have a cup of coffee, come back, do the chest. And in the chest side, we roll the patient on the left side down, right side up, make a big hole, use some more bits of fancy kit, and this is the bit that's important for me. This bit makes the join. This is a circular stapler. That's the anvil that goes in the top of the esophagus, in like that, and we fire 2 layers of staples around the join, and then it cuts in between. And I put that into the top of the esophagus. You just saw me doing that. I pull the stomach up from below, chop the specimen off. That's what I came for. Doesn't look much. That's not for lunch. That is the specimen that gets taken to the path lab. Actually, we take bits of that over to the research facility and use it for some innovative studies. And then we use this bit of technology, which has replaced hand sewing a join. This is the circular stapler. Dock it onto its end, tighten it up, and in a minute, you will see me pray. Just there. And I always say a little prayer at that point, because I don't want that joint to break down. I want that to work permanently. Bit more technology, bit more kit, which we can all use laparoscopically as well. We do laparoscopic versions of this operation, but actually there's no evidence that one's better than the other yet. And then I do a bit of anaesthetist baiting. We'll go on to the next one. You can probably imagine that operation is associated with a significant level of risk. If you'd have had it 20 years ago, your risk of death would have been about 1 in 10. It's quite high. Now it's about 1 in 50. But your risk of a major complication after that operation is about 1 in 3. And the thing is, I can't tell you which one it will be, which one of you will get the complication. The patients that come to see in my clinic, I quote them those figures and I say you've got a 1 in 50 chance of death and a 1 in 3 chance of a major complication. Disruption in the joint or a chest infection that might keep you in hospital for 100 days when we're trying to send you home at day 8. And they say, well, how do you know if it's me or not? And I say, I don't, to some extent. And I'll talk about how we're predicting that risk in a minute. And the important thing to understand about this is that a death, a major complication, a near miss, or a never event, which never happen obviously, are very rarely due to a single action or a single person. They're more likely to be due to a series of small things that line up, that put a hole through the adventure. Okay? And we can modify those small things. We can make every one of those small things better, a bit like the process of marginal gains with the British cycling team to improve overall outcome. So how do we modify risk across this pathway? Well, I'm going to show you how UHS is leading the field really in modifying risk around the process of chemotherapy, what we do and how we've learned from industry about the process of surgery, and then how we're doing something to modify risk post-operatively. I won't keep you too long. So this is work done by Professor Mike Grocott, who leads the world really in exercise physiology around operations. He's a chap who's been up Everest and has been on the telly. He's a nice guy and he's famous, so I thought I'd give you the Everest story. This is not Mike, obviously. This bloke hasn't been up Everest, I don't think. But this is a man, he might have been. This is a man doing exercise testing, cardiopulmonary exercise testing. We know that a person's fitness is directly related to their ability to survive major trauma or an operation. Makes sense, really. The fitter you are, the more likely you are to have reserve to withstand the operation that you have. And we can test that by putting them on an exercise bike, measuring inspired and expired gases, measuring heart rate, ECG tracings, we can get a really good idea about how well this person's heart and lungs work to deliver oxygen to their tissues. And that's the key. Can they deliver oxygen to their tissues? So we put them on the bike and we gradually increase the amount of work that they have to do until they can't work anymore. And we understand where they switch from aerobic to anaerobic respiration and their maximum effort. I've been on this bike. I have to tell you, to start with, it's quite good fun. At the end, it is not good fun in the slightest. And you feel like things are about to fall off at this point. But it's worth doing. Yeah. But it's only worth doing if it makes a difference to the patients. We know that in other branches of medicine, it is associated with survival. And we know that this is 3 studies in upper GI cancer. And you don't need to know really what this says, apart from there is a relationship between the amount of oxygen you can deliver to your tissues and the amount of cardiopulmonary complications you will get in the post-operative period. And that's really important because for esophageal cancer, the commonest complication is a lung infection or a respiratory problem. So we can predict respiratory outcome based on preoperative respiratory function. Can we intervene? Well, this is a study done in colorectal cancer, and patients with colorectal cancer get preoperative chemotherapy and radiotherapy. Now, we're starting to do that in this hospital for esophageal cancer as well, leading the UK in that field. And these patients were split into 2 groups. A group that did nothing. They just had the preoperative chemoradiotherapy, and a group that had a defined exercise program to go along with their chemoradiotherapy. And what this shows is, this is their VO2 at peak. This is how good they are at exercise. Okay? That's pre giving them the chemotherapy. That's post chemotherapy. And they both get worse. Chemotherapy and radiotherapy together does something to your ability to exercise. It makes you worse exercise, not unsurprisingly. Okay? But if you've been on the exercise program, when you have your holiday post chemoradiotherapy before your operation, those that exercise recover. Those that don't exercise don't. So we can intervene to make these people better. This is the concept of prehabilitation that Mike in this trust is leading on. We can make patients physiologically better before we give them a huge insult. And we're going to launch, hopefully, one of the biggest trials in esophageal surgery to look at this. So we've talked about here how we can modify risk around the preoperative phase. What about intraoperatively? What have we learned and what do we do intraoperatively? I'm going to show you one short video clip that is at the beginning of an operation and stuff that we've stolen directly from the airline industry.
Pete, please. Okay, so Tim Underwood, consultant surgeon.
Alan Scrubness.
Inga Scrubness. Hannah Auxiliary.
Thomas Student-House.
Abby Student. Louise Auxiliary.
Ryan said, Jerry Anderson, ADP.
Andy Anderson, consultant.
Okay, so Ryan's not had any chemotherapy, who's a big, early road worker who smoked all of his life and drunk most of it probably as well. Okay, so we're expecting it to be proper male abdomen and male chest, so be on the inside. Maybe it's difficult, but we've got time, take time, get it right.
Okay, can you
So
see that
Inga, you've
now?
got the name down for the patient,
Yeah.
far away. Yeah,
Date of birth,
yes.
hospital number.
Okay, it is consented for an ivolous esophagectomy and feeding jejunostomy by me on the 26th of September and signed by him then and confirmed today by me with him.
That's all good.
All initial sign.
Yeah, these numbers match. He has no allergies.
Antibiotic prophylaxis within the last
In.
60 minutes.
In.
Patient warming on.
On.
Hair removal. Not applicable.
Doesn't need me actually.
Okay. Glycemic control.
Not applicable.
Right.
Cool. And floatrons will be on.
Proton.
So that's DVT prophylaxis on, plugged in, working, and he's got TEDs on. And he's got an IVC filter in.
Correct.
And he stopped his Clexane
2 days ago.
2 days ago. So he'll go back on to Clexane after operation. We'll discuss what dose depending on what we find in surgery. Anything else?
No.
Check complete, okay?
Yeah.
That's the operation. Good.
We do that every time, every patient. We want to get it right first time. It's modifying the small things that makes a big difference. That's how we've learned from industry, and we're now getting quite good at risk, and I think industry can now learn a little bit from us about risk modification. So we deliver someone, and that's him actually, we deliver someone day 1 post-op, hopefully who looks something like this, and we get him up and out of bed, and we get him exercising with his drains in, that sort of thing, and we want to send him home at day 8. The problem is that if he's going to get a complication, an anastomotic leak, it's likely to happen at day 7. And we have very little indication that it's going to happen until it happens. You don't see a rise in pulse or temperature or changes in blood pressure until very late in the day, just before the event or at the time of the event happening. But can we predict any earlier that it's going to take place? Well, we can actually. And we can because we can measure the insult that the body has undergone as an event of the operation. So we can use routine markers of inflammation in the blood that we measure every day, and because we collect this sort of high quality data set, we can analyse it. This was based on 258 patients who underwent esophagectomy over a 5-year period, and we were able to do 2 data sets, one to develop the test and one to validate it. Yeah, and some graphs that I will explain. Essentially, an anastomotic leak is the breakdown in the join, and patients in an anastomotic leak are shown in red. And what you can see is with serum albumin, it doesn't matter what these are, but this is albumin, which is a marker of inflammation in this context. Patients with an anastomotic leak have a lower albumin from about day 3 onwards. Patients with an anastomotic leak have a rise in their CRP, C-reactive protein, from about day 2 or 3 onwards. The same patients have a rise in their white blood cell count from about day 3 onwards. Individually, these markers will predict leak to a certain extent, but they're not very accurate. So what we did with this big data set was say, right, we'll put them all together. We'll join them together in a model score, and we called this the none score for reasons that you don't want to know about and are beyond me. And we can predict with 85% accuracy on day 4 whether or not a patient will have an anastomotic leak or a major complication at day 7. It's all very well and good, but can you modify what happens? The important thing to understand is that the sensitivity of this test is 100%. If you have or are going to have an anastomotic leak, your score will have been above 10 at day 4. We might get some false positives, but not missing anyone with a catastrophic consequence is really important. And this has now been put into our enhanced recovery pathway so that there is a mandated re-review by a consultant on the result of that test. We can then withhold oral intake if we want to. We can get a contrast swallow or a CT scan to rule out the potential complication to modify the patient's outcome. Yeah. So we've got it embedded in our enhanced recovery pathway. We've also done some reanalysis and realised that actually, overall, the higher your none score, the longer your length of stay. So we're doing things around understanding what modifies length of stay. Actually, our length of stay has come down from 12 days to 8 days over the last 2 years. So we're doing really well about saving some money for the trust there as well. So hopefully I've shown you with a whistle-stop tour of esophageal cancer that it's a really bad thing to have. You don't want it, okay? But if you do have it and you're operable, you go through a big, long process that's risky. But we are understanding how to modify risk here, how to modify risk here, and how to modify risk here. This can't be done without a number of things, and we have a number of things in this trust. We have patients. Lots and lots of patients, and patients are at the core of everything that we do. Patient-centered, patient-focused care. Don't forget that. We should never forget that. We have data. We have huge data sets that is well collated, is interrogatable, if that's a word, and we have good teams of high-quality clinicians who understand the clinical questions to ask and understand how to answer them and are able to interrogate that data. Without them, I wouldn't exist. All of the work I've shown you really has been done by other people, and they just asked me to stand up and talk about it. So without them, I wouldn't be here. And I think, if you click on to the next one, if anyone would be interested to hear anything else that I've got to say or do, and God knows why you would, but you can get it on there. So thank you for listening.